Hello, my name is Josephine Ho, and I will be presenting the Diabetes Canada 2018 Clinical Practice Guidelines for Type 1 Diabetes in Children and Adolescents. On behalf of the chapter co-authors Diane Werrett, Céline Huot, Laurent Legault, Miranda Nakla, and Elizabeth Roslowski. Key changes include a new recommendation on an A1C target of less than or equal to 7.5% for all children and adolescents less than 18 years of age. In addition, the use of a psychosocial risk index aid to identify children and adolescents at high risk of poor glycemic control. For the overview of the chapter, we will be touching on education, glycemic targets, insulin therapy, glucose monitoring, nutrition, hypoglycemia, DKA management, complications, immunization, smoking, sexual health, psychology, comorbidities, and transition to adult care. Diabetes mellitus is the most common endocrine disease and one of the most common chronic conditions in children. Type 2 diabetes and other types of diabetes, including genetic defects of beta cell function, such as maturity-onset diabetes of the young, are being increasingly recognized in children and should be considered when clinical presentation is atypical for type 1 diabetes. Education from diagnosis onwards is complex, touching on a range of issues, medical and social. Therefore, it is best done by an interprofessional team trained in pediatric diabetes. Children with new-onset type 1 diabetes and their families require intensive diabetes education by an interprofessional pediatric diabetes healthcare team. Education topics should include prevention, detection, and treatment of hypoglycemia, insulin action and administration, dosage adjustment, blood glucose and ketone testing, sick day management, prevention of DKA, nutrition and exercise. Anticipatory guidance and healthy behavior counseling should be part of routine care during critical developmental transitions, for example at school entry and at the beginning of high school. Healthcare providers should regularly initiate discussions with children and their families about school, diabetes camp, psychological issues, fear of hypoglycemia, substance use, driving, and career choices. All children with diabetes should have access to an experienced pediatric diabetes healthcare team that includes either a pediatric endocrinologist or pediatrician with diabetes expertise, a dietitian, diabetes nurse educator, social worker, and mental health professional for specialized care starting at diagnosis. Children with new-onset type 1 diabetes who are medically stable should receive their initial education and management in an outpatient setting, provided that appropriate personnel and daily communication with the diabetes healthcare team are available. Change of physician or diabetes healthcare team can have major impact on disease management and metabolic control. 25% to 65% of young adults have no medical follow-up during the transition. Those with no follow-up are more likely to experience hospitalization for diabetic ketoacidosis during this period. Organized transition services may decrease the rate of loss of follow-up. To ensure ongoing and adequate diabetes care, adolescents should receive care from a specialized program aimed at creating a well-prepared and supported transition to adult care that is initiated early and includes a transition coordinator, patient reminders, and support and education promoting autonomy and self-management skills. A new change for the 2018 Diabetes Canada Clinical Practice Guidelines includes a new single target of less than or equal to 7.5% for all children. Achieving adult targets for metabolic control is not always indicated and may be unsafe for some children. Achieving targets may require much work on the part of the family and diabetes healthcare team to find the right insulin approach. Clinical judgment is required to tailor goals to the patient. Episodes of frequent or severe hypoglycemia have been associated with poorer cognitive function in some follow-up studies. Research suggests that knowledge of glycemic targets by patients and parents and consistent target setting by the diabetes healthcare team was associated with improved metabolic control. Glycemic targets for children less than 18 years of age would be a hemoglobin A1C of less than or equal to 7.5%, with fasting plasma glucose pre-meals 4.0 to 8.0 millimoles per liter, and 2-hour post-meal goals of 5.0 millimoles per liter to 10 millimoles per liter. Caution is required to minimize severe or excessive hypoglycemia. Consideration should be given to using preprandial targets of 6 to 10 millimoles per liter, as well as higher A1C targets in children and adolescents who have had severe or excessive hypoglycemia or who have hypoglycemia unawareness. Children and adolescents less than 18 years of age should aim for an A1C target of less than or equal to 7.5%. Attempts should be made to safely reach the recommended glycemic target while minimizing the risk for severe or recurrent hypoglycemia. Treatment targets should be tailored to each child, taking into consideration individual risk factors for hypoglycemia. In children less than 6 years of age, particular care to minimize hypoglycemia is recommended because of the potential association in this group between severe hypoglycemia and later cognitive impairment. Diabetes control may worsen during adolescence, possibly due to the following factors: adolescent adjustment issues, psychosocial distress, intentional insulin emission, physiologic insulin resistance. Children with persistently poor glycemic control, for example, an A1C greater than 10%, should be assessed with a validated tool by a specialized pediatric diabetes healthcare team for comprehensive interdisciplinary assessment and referred for psychosocial support as indicated. Intensive family and individualized psychological interventions aimed at improving glycemic control should be considered to improve chronically poor metabolic control. It is reasonable to start with a basic insulin regimen, for example, a minimum of 3 injections per day, but a more intensive approach is indicated if success is not achieved despite good efforts. There are currently a wide variety of types of insulin available for use in type 1 diabetes. These include bolus and basal insulins. Rapid-acting insulin analogs, typically onset in 10 to 15 minutes, have a peak at 1 to 2 hours and a duration of approximately 3 to 5 hours. Short-acting insulins, typically onset in 30 minutes, have a peak in 2 to 3 hours and have a duration of approximately 6 hours. Basal insulins include intermediate-acting insulins and typically onset in 1 to 3 hours with a peak at 5 to 8 hours and a duration of up to 18 hours. Long-acting basal insulin analogs typically onset in 90 minutes and have a duration of action of up to 24 hours. This table shows the wide variety of newer insulin analogs and preparations that are available. Some of the benefits include new concentrated insulin so that patients are able to give smaller volume injections if they have higher doses, new insulin analogs that have an onset of duration faster than previous, and new basal insulins that have a duration of action of greater than 30 hours to 42 hours. Also available are premixed insulins that contain a fixed ratio of insulin in a single vial or cartridge. This illustration shows the typical insulin that would be secreted by a person without diabetes. Usually with a meal, insulin levels would spike in response to change in blood glucose levels. There is always a basal amount of insulin that is also secreted. This green line illustrates what a human basal insulin profile would look like. This purple line indicates what an analog basal insulin profile would look like. As you can see, there is less of a peak, and the profile more closely mimics a physiologic basal insulin. The orange lines indicate human bolus insulin. The burgundy lines indicate analog bolus insulin. As you can see with the analogs, the onset of action is faster and again more closely mimics physiologic insulin secretion in response to a meal. Insulin is the mainstay of medical management. The choice of insulin regimen really depends on many factors. These include the child's age, the duration of diabetes, family lifestyle, socioeconomic factors, family, patient, and physician preferences. A starting regimen should typically comprise greater than or equal to 2 daily bolus injections and greater than or equal to 1 basal insulin injection. If the initial regimen fails to meet glycemic targets, more intensive management may be required. 3 methods of intensive diabetes management can be used at any age. This is a similar regimen with more frequent injections, a basal bolus regimen using long and rapid-acting insulin analogs, or continuous subcutaneous insulin infusion or insulin pump therapy. Children with new onset diabetes should be started on boluses of rapid-acting insulin analogs combined with basal insulin. For example, intermediate-acting insulin or long-acting basal insulin analog, using an individualized regimen that best addresses the practical issues of daily life. Insulin therapy should be assessed at each clinical encounter to ensure it still enables the child to meet A1C targets, minimizes the risk of hypoglycemia, and allows flexibility in carbohydrate intake, daily schedule, and activities. If these goals are not being met, an intensified diabetes management approach, including increased education, monitoring, and contact with the diabetes team, should be used. Treatment options may include the following: increasing frequency of injections, change in the type of basal and or bolus insulin, or change to continuous subcutaneous insulin infusion therapy. Self-monitoring of blood glucose is an essential part of management of type 1 diabetes. Subcutaneous continuous glucose sensors allow detection of asymptomatic hypoglycemia and hyperglycemia. Subcutaneous continuous glucose sensors may have a beneficial role in children and adolescents, but evidence is not as strong as in adults. All children with type 1 diabetes should receive counseling from a registered dietitian experienced in pediatric diabetes. Children with diabetes should follow a healthy diet as recommended for children without diabetes in Eating Well with Canada's Food Guide. There is no evidence that one form of nutrition therapy is superior to another in attaining age-appropriate glycemic targets. Use of insulin to carbohydrate ratios may be beneficial but is not required. The effect of protein and fat on glucose absorption must also be considered. Nutrition therapy should be individualized based on the child's nutritional needs, eating habits, lifestyle ability, and interests, and must ensure normal growth and development without compromising glycemic control. All families should understand the importance of hypoglycemia, both severity and frequency, along with treatment and follow-up strategies. Hypoglycemia is a major obstacle for children with type 1 diabetes and can affect their ability to achieve glycemic targets. Significant risk of hypoglycemia often necessitates less stringent glycemic goals, particularly for younger children. There is no evidence in children that one insulin regimen or mode of administration is superior to another for reducing non-severe hypoglycemia. This table lists some examples of carbohydrate for treatment of mild to moderate hypoglycemia. If a child's weight is less than 15 kilograms, the amount of carbohydrate recommended would be 5 grams. If they are 15 to 30 kilograms, the amount of carbohydrate recommended would be 10 grams. If they are greater than 30 kilos, the amount of carbohydrate recommended would be 15 grams. This amount of carbohydrate can be achieved with various sources such as glucose tablets, dextrose tablets, or juice. Frequent use of continuous glucose monitoring in a clinical care setting may reduce episodes of hypoglycemia. In children, the use of mini doses of glucagon has been shown to be useful in the home management of mild or impending hypoglycemia associated with inability or refusal to take oral carbohydrate. A typical dose would be 10 micrograms times the age in years. The dose range would be 20 to 150 micrograms. For severe hypoglycemia, a child should be given glucagon. If their age is less than or equal to 5 years, then a dose of 0.5 milligrams of glucagon, either subcutaneously or intramuscularly, should be administered. If their age is greater than 5 years, then a dose of 1 milligram subcutaneously or intramuscularly should be administered. The diabetes care team should be contacted following a severe hypoglycemic event. In addition, consideration to reducing insulin doses in the short term to avoid a repeat event should be considered. In children, the use of mini doses of glucagon, 10 micrograms per year of age, with a minimum dose of 20 micrograms and a maximum dose of 150 micrograms, should be considered in the home management of mild or impending hypoglycemia associated with the inability or refusal to take oral carbohydrate. In the home situation, severe hypoglycemia in an unconscious child greater than 5 years of age should be treated with 1 milligram of glucagon subcutaneously or intramuscularly. In children less than 5 years of age, a dose of 0.5 milligrams of glucagon should be given. The episode should be discussed with the diabetes healthcare team as soon as possible, and consideration given to reducing the insulin doses for the next 24 hours to prevent further severe hypoglycemia. Dextrose 0.5 to 1 gram per kilo should be given intravenously over 1 to 3 minutes to treat severe hypoglycemia with unconsciousness when intravenous access is available. Regular physical activity greater than or equal to 3 times per week for greater than or equal to 60 minutes each time should be encouraged for all children with diabetes. Diabetic ketoacidosis is the leading cause of morbidity and mortality in children with diabetes. Strategies are required to prevent the development of diabetic ketoacidosis. In new onset diabetes, diabetic ketoacidosis can be prevented through earlier recognition and initiation of insulin therapy. Caution is necessary in management of pediatric diabetic ketoacidosis due to increased risk of cerebral edema. Failing to take insulin or poor sick day management can lead to diabetic ketoacidosis. Risk factors for diabetic ketoacidosis can include the following: children with poor control or previous episodes of diabetic ketoacidosis, peripubertal and adolescent girls, children on pumps or long-acting insulin analogs, children with psychiatric disorders, and those with difficult family circumstances. The frequency of diabetic ketoacidosis in established diabetes can be decreased with education, behavioral intervention, and family support, as well as access to 24-hour telephone services for parents of children with diabetes. Approximately 0.5 to 1% of pediatric cases are complicated by cerebral edema, which is associated with significant morbidity, 21 to 35%, and mortality, 21 to 24%. In order to help avoid cerebral edema, it is advised to not administer hypotonic fluid rapidly and to not give an IV insulin bolus. IV insulin infusion should be started 1 hour after fluid resuscitation has begun. Risk factors for developing cerebral edema include a younger age, less than 5 years of age, new onset diabetes, a high initial serum urea, a low initial partial pressure of arterial carbon dioxide, rapid administration of hypotonic fluids, IV bolus of insulin, early IV insulin infusion within the first hour of fluids, failure of serum sodium to rise during treatment, and use of bicarbonate. This algorithm shows the approach to management of diabetic ketoacidosis in children. As you can see, after obtaining a clinical history, examining the child, and ordering appropriate investigations, a key component is contacting someone with expertise in the management of diabetic ketoacidosis in children. For most children, IV fluid requirements should be corrected over 48 hours, and an IV insulin infusion should be started at 0.1 units per kilo per hour, 1 to 2 hours after IV hydration is initiated. The child should be monitored closely in a critical care setting with regular evaluation. Cerebral edema is a rare but serious complication and must be closely watched for. Immediate assessment of a child with diabetic ketoacidosis includes the clinical history, looking for symptoms such as polyuria, polydipsia, weight loss, abdominal pain, tiredness, vomiting, and confusion. Clinical signs such as dehydration, Kussmaul respirations, ketone-smelling breath, lethargy, drowsiness, and vomiting. Biochemical features including ketones, elevated blood glucose, acidemia, blood gases, urea, electrolytes, and other investigations as indicated, for example, looking for infections or other illnesses. If the clinical assessment of the child in diabetic ketoacidosis shows that they are in shock, then appropriate resuscitation should be administered, including assessment of airway, breathing, and circulation. Fluid boluses of normal saline, 10 to 20 milliliters per kilo over 1 to 2 hours, can be used and repeated until circulation is restored, but not exceeding 30 milliliters per kilo. If the child has dehydration but is not in shock, then IV therapy is used to correct the fluid deficit over 48 hours. If there's minimal dehydration and the patient is tolerating oral fluid, then it is recommended to start with oral hydration and subcutaneous insulin initially. Continuous IV insulin infusion at 0.1 units per kilo per hour can be started 1 to 2 hours after IV hydration is initiated. Patients with diabetic ketoacidosis require close observation, including initially hourly blood glucose readings and electrolytes every 2 hours after the start of IV therapy. Hourly fluid input and output should be monitored, and neurological status should also be closely followed at least hourly. ECG for T-wave changes should be monitored. If the acidosis is not improving, the patient should be re-evaluated for fluid and insulin delivery. If the blood glucose level is less than or equal to 17 millimoles per liter and the plasma glucose is falling at greater than 5 millimoles per liter per hour, then IV therapy should be changed to include some dextrose to avoid hypoglycemia. Once the patient has clinically improved and is able to tolerate oral fluids, then a transition to subcutaneous insulin should be initiated with stopping IV insulin after an appropriate interval. If any signs of neurological deterioration are noted, such as headache, slowing of the heart rate, irritability, or decreased level of consciousness, incontinence, or specific neurological signs, then it is important to assess whether or not the patient may have cerebral edema. Mannitol and hypertonic saline are options to use in treatment of cerebral edema. The patient should be monitored closely in ICU, and cranial imaging should be considered after the patient is stabilized. To prevent diabetic ketoacidosis in children with diabetes, targeted public awareness campaigns should be considered to educate parents and other caregivers, for example teachers, and healthcare providers about the early symptoms of diabetes. Immediate assessment of ketone and acid-base status should be done in any child presenting with new onset diabetes. Comprehensive education and support services, as well as a 24-hour telephone service, should be available for families of children with diabetes. Diabetic ketoacidosis in children should be treated according to pediatric specific protocols. If appropriate expertise and facilities are not available locally, there should be immediate consultation with a center with expertise in pediatric diabetes. In children in diabetic ketoacidosis, rapid administration of hypotonic fluids should be avoided. Circulatory compromise should be treated with only enough isotonic fluids to correct circulatory inadequacy. Replacement of fluid deficit should be extended over a 48-hour period with regular assessments of fluid status. In children in diabetic ketoacidosis, an intravenous insulin bolus should not be given. The insulin infusion should not be started for at least 1 hour after starting fluid replacement therapy. An intravenous infusion of short-acting insulin should be used at an initial dose of 0.05 to 0.1 units per kilo per hour, depending on the clinical situation. In children in diabetic ketoacidosis, once blood glucose reaches less than or equal to 17 millimoles per liter, intravenous dextrose should be started to prevent hypoglycemia. the dextrose infusion should be increased rather than reducing insulin to prevent rapid decreases in glucose. The insulin infusion should be maintained until pH normalizes and ketones have mostly cleared. In children in DKA, administration of sodium bicarbonate should be avoided except in extreme circulatory compromise, as this may contribute to cerebral edema. In children in diabetic ketoacidosis, either mannitol or hypertonic saline may be used in the treatment of cerebral edema. Nephropathy, retinopathy, neuropathy, and hypertension are rare in pediatric diabetes. Screening efforts should focus most attention on post-pubertal patients with longer duration and poorer control of their diabetes. Prepubertal children and those in the first 5 years of diabetes should be considered at very low risk for microalbuminuria. A first morning urine albumin to creatinine ratio has high sensitivity and specificity for the detection of microalbuminuria. A random albumin to creatinine ratio may be compromised in adolescents due to their higher frequency of exercise-induced proteinuria and benign postural proteinuria. Abnormal random albumin to creatinine ratios of greater than 2.5 mg per millimole require confirmation with a first morning albumin to creatinine ratio or timed urine overnight collection, as abnormal albumin to creatinine ratio frequently normalizes spontaneously. Treatment is indicated only for those adolescents with persistent albuminuria. There are no long-term intervention studies assessing the effectiveness of ACE inhibitors or angiotensin receptor blockers in delaying progression to overt nephropathy in adolescents with microalbuminuria. Therefore, treatment guidelines are based on adult data. Retinopathy is rare in prepubertal children with type 1 diabetes and in postpubertal adolescents with good metabolic control. If a child is aged greater than or equal to 15 years and has diabetes of 5 years, the recommendation would be to begin annual screening. If the child has had diabetes for 5 to 10 years and has a normal eye exam and has good glycemic control, the recommendation would be to screen every 2 years. Neuropathy is mostly subclinical in children. Vibration and monofilament testing have suboptimal sensitivity and specificity in adolescents, and persistence of abnormalities is an inconsistent finding. The only treatment modality for children and adolescents is intensified diabetes management to achieve and maintain glycemic targets. Most children with type 1 diabetes should be considered at low risk for vascular disease associated with dyslipidemia. The exceptions are those with a longer duration of disease, microvascular complications, cardiovascular risk factors including smoking, hypertension, obesity, or a family history of premature cardiovascular disease. Screening for dyslipidemia is recommended to begin at greater than or equal to 12 years of age, or at less than 12 years of age in people with specific risk factors. Repeat screening is recommended every 5 years. Statin therapy has only rarely been studied specifically in children with diabetes. There is no evidence linking specific LDL cutoffs in children with diabetes with long-term outcomes. Up to 16% of adolescents with type 1 diabetes have hypertension. Screening blood pressures are recommended at least twice a year. The role of ambulatory blood pressure monitoring in routine care remains uncertain. Treatment is recommended according to the guidelines for children without diabetes. This table summarizes the recommended screening for complications. For nephropathy, it is recommended to screen yearly, commencing at 12 years of age in those with a duration of type 1 diabetes greater than or equal to 5 years. The preferred screening method is a first morning random urine albumin to creatinine ratio. If there is an abnormal albumin to creatinine ratio, confirmation is required at least 1 month later with a first morning albumin to creatinine ratio, and if that is abnormal, should be followed by a timed overnight or 24-hour split urine collection for albumin excretion rate. Repeated sampling should be done every 3 to 4 months over a 6 to 12 month period to demonstrate persistence. For retinopathy, yearly screening commencing at 15 years of age with a duration of diabetes greater than or equal to 5 years is recommended. The screening interval can increase to 2 years if good glycemic control, duration of diabetes of less than 10 years, and no retinopathy noted at initial assessment. The recommended screening method is a 7 standard field stereoscopic color fundus photography with interpretation by a trained reader, or direct ophthalmoscopy or indirect slit lamp fundoscopy through dilated pupil, or digital fundus photography. For neuropathy, postpubertal adolescents should be screened with poor metabolic control yearly after 5 years duration of diabetes. The screening method is questioning and exam for symptoms of numbness, pain, cramps, and paresthesia, as well as sensation, vibration sense, light touch, and ankle reflexes. For dyslipidemia, the screening should be delayed post-diabetes diagnosis until metabolic control has stabilized. It is recommended to screen at greater than or equal to 12 years of age or less than 12 years of age with a BMI greater than the 97th percentile, family history of hyperlipidemia, or premature cardiovascular disease. The recommended screening method is a fasting lipid profile. For hypertension, all children with type 1 diabetes should be screened at least twice a year with a clinic blood pressure measurement using the appropriate cuff size. Children greater than or equal to 12 years with diabetes duration greater than 5 years should be screened annually for chronic kidney disease with a first morning urine albumin to creatinine ratio or a random albumin to creatinine ratio. Abnormal results should be confirmed at least 1 month later with a first morning albumin to creatinine ratio and, if abnormal, followed by a timed, overnight, or 24-hour split urine collection for albumin excretion rate. Albuminuria, defined as an albumin to creatinine ratio greater than 2.5 milligram per millimole, or an albumin excretion rate of greater than 20 micrograms per minute, should not be diagnosed unless it is persistent, as demonstrated by 2 consecutive first morning albumin to creatinine ratios or a timed collections obtained at 3 to 4 month intervals over a 6 to 12 month period. Children greater than or equal to 12 years with persistent albuminuria should be treated according to the adult guidelines. Children greater than or equal to 15 years with 5 years of diabetes duration should be annually screened and evaluated for retinopathy by an expert professional. The screening interval can be increased to every 2 years in children with type 1 diabetes who have good glycemic control, duration of diabetes less than 10 years, and no significant retinopathy, as determined by an expert professional. Children greater than or equal to 15 years with 5 years duration and poor metabolic control should be questioned about symptoms of numbness, pain, cramps, and paresthesia, and examined for skin sensation, vibration sense, light touch, and ankle reflexes. Children with type 1 diabetes who are less than 12 years of age should be screened for dyslipidemia if they have other risk factors such as obesity, body mass index greater than the 97th percentile for age and gender, and or a family history of dyslipidemia or premature cardiovascular disease. Routine screening for dyslipidemia should begin at 12 years of age, with repeat screening after 5 years. Once dyslipidemia is diagnosed in children with type 1 diabetes, the dyslipidemia should be monitored regularly and efforts should be made to improve metabolic control and promote healthy behaviors. While it can be treated effectively with statins, a specific cutoff to initiate the treatment is yet to be determined in this age category. All children with type 1 diabetes should be screened for hypertension at least twice annually. Children with type 1 diabetes and blood pressure readings persistently above the 95th percentile for age should receive healthy behavior counseling, including weight loss if overweight. If blood pressure remains elevated, treatment should be initiated based on recommendations for children without diabetes. We will now look at some other considerations for children and adolescents with type 1 diabetes, including immunization, smoking, contraception and sexual health counseling, psychological and psychiatric issues, and eating disorders. There is no evidence supporting increased morbidity or mortality from influenza in children with type 1 diabetes. The management of type 1 diabetes can be complicated by illness. For this reason, parents may choose to immunize their children. Smoking prevention and cessation should be emphasized throughout childhood and adolescence. Adolescents with diabetes should receive regular counseling about sexual health and contraception. Pregnancy in adolescent females with type 1 diabetes with suboptimal metabolic control may result in higher risks of maternal and fetal complications than in older women with type 1 diabetes. Oral contraceptives, intrauterine devices, and barrier methods can be used safely in the vast majority of adolescents. Influenza vaccination should be offered to children with diabetes as a way to prevent an intercurrent illness that could complicate diabetes management. Formal smoking prevention and cessation counseling should be part of diabetes management for children with diabetes. Adolescents should be regularly counseled around alcohol and substance use. Adolescent females with type 1 diabetes should receive counseling on contraception and sexual health in order to prevent unplanned pregnancy. For children, and particularly adolescents, there is a need to identify psychological disorders associated with diabetes and to intervene early to minimize the impact over the course of development. Children and adolescents with diabetes have significant risks for psychological problems, including depression, anxiety, eating disorders, and externalizing disorders. The risks increase exponentially during adolescence. Psychological disorders predict poor diabetes management and control, and consequently negative medical outcomes. Conversely, as glycemic control worsens, the probability of psychological problems increases. Presence of psychological symptoms and diabetes problems in children and adolescents are often strongly affected by caregiver and family distress. 10% of adolescent females with type 1 diabetes meet the Diagnostic and Statistical Manual of Mental Disorders criteria for an eating disorder, compared to 4% of their age-matched peers without diabetes. Eating disorders are associated with poor metabolic control and earlier onset and more rapid progression of microvascular complications. Eating disorders should be suspected in those adolescent and young adults who are unable to achieve and maintain metabolic targets, especially when insulin omission is suspected. It is important to identify individuals with eating disorders because different management strategies are required to optimize metabolic control and prevent microvascular complications. Children and adolescents with diabetes, along with their families, should be screened regularly for psychosocial or psychological disorders and should be referred to an expert in mental health and/or psychosocial issues for intervention when required. Adolescents with type 1 diabetes should be regularly screened using non-judgmental questions about weight and body image concerns, dieting, binge eating, and insulin omission for weight loss. Always consider the possibility of autoimmune thyroid and adrenal disease and celiac disease, particularly when there are suggestive signs or symptoms. Autoimmune thyroid disease occurs in 15 to 30% of individuals with type 1 diabetes. The risk for autoimmune thyroid disease during the first decade of diabetes is directly related to the presence or absence of thyroid antibodies. Hypothyroidism is most likely to develop in girls at puberty. Early detection and treatment of hypothyroidism will prevent growth failure and symptoms of hypothyroidism. Hyperthyroidism also occurs more frequently in association with type 1 diabetes than in the general population. Primary adrenal insufficiency is rare, even in those with type 1 diabetes. Targeted screening is required in those with unexplained recurrent hypoglycemia and decreasing insulin requirements. Celiac disease can be identified in 4 to 9% of children with type 1 diabetes. In 60 to 70% of these children, the disease is asymptomatic. There is good evidence that treatment of classic or atypical celiac disease with a gluten-free diet improves intestinal and extraintestinal symptoms and prevents the long-term sequelae of untreated disease. There is no evidence that untreated asymptomatic celiac disease is associated with short or long-term health risks. A gluten-free diet improves health in these individuals. Universal screening for and treatment of asymptomatic celiac disease remains controversial. This table summarizes the screening recommendations for comorbid conditions. For autoimmune thyroid disease, all children with type 1 diabetes should be screened at diagnosis and every 2 years thereafter using a serum TSH level. If there are positive thyroid antibodies, thyroid symptoms, or goiter, then the TSH level and a thyroid peroxidase antibody, if previously negative, could be done every 6 to 12 months. For primary adrenal insufficiency, children should be screened if there is evidence of unexplained recurrent hypoglycemia and decreasing insulin requirements. A screening test would include an 8 a.m. serum cortisol with serum sodium and potassium level. For celiac disease, indications for screening would include recurrent gastrointestinal symptoms, poor linear growth, poor weight gain, fatigue, anemia, unexplained frequent hypoglycemia, or poor metabolic control. Children with type 1 diabetes who have antithyroid antibodies should be considered high risk for autoimmune thyroid disease. Children with type 1 diabetes should be screened at diabetes diagnosis with repeat screening every 2 years using a serum thyroid-stimulating hormone and thyroid peroxidase antibodies. More frequent screening is indicated in the presence of positive antithyroid antibodies, thyroid symptoms, or goiter. Children with type 1 diabetes and symptoms of classic or atypical celiac disease should undergo celiac screening, and if confirmed, be treated with a gluten-free diet to improve symptoms and prevent the long-term sequelae of untreated classic celiac disease. Discussion of the pros and cons of screening and treatment of asymptomatic celiac disease should take place with children and adolescents with type 1 diabetes and their families. In summary, the guidelines for children and adolescents differ from those of adults in a number of ways. There is less aggressive A1C target acceptable in children, less intensive screening for complications of diabetes in the younger years due to lower incidence, greater caution around diabetic ketoacidosis management given the risk of cerebral edema, and greater awareness of unique psychosocial needs as children progress through developmental stages. Some key messages include suspicion of diabetes in a child should lead to immediate confirmation of the diagnosis and initiation of treatment to reduce the likelihood of diabetic ketoacidosis. Management of pediatric diabetic ketoacidosis differs from diabetic ketoacidosis in adults because of the increased risk for cerebral edema. Pediatric protocols should be used. Children should be referred for diabetes education, ongoing care, and psychosocial support to a diabetes team with pediatric expertise. A key message for people with children and adolescents living with type 1 diabetes is that when a child is diagnosed with type 1 diabetes, the role of a caregiver becomes more important than ever. Family life and daily routines may seem more complicated in the beginning, but over time and with the support of your diabetes team, these will improve. You will discover that your child can have a healthy and fulfilling life with diabetes. The full guidelines, interactive tools, and other useful resources can be accessed on the guidelines website. The information is also accessible on the Diabetes Canada app that's available in the App Store, as well as for Android in the Google Play Store. For the full guidelines, interactive tools, and other useful resources, please see the Diabetes Canada Clinical Practice Guidelines at www.guidelines.diabetes.ca and the website at www.diabetes.ca. Thank you.